Let's do it.
Oh, hey, Chris.
Hey, Chuck, how are you?
I'm really, really well, and I'm super excited.
I'm excited too. It's a big episode for us, starting a new venture with some friends over in Europe.
We are hosting a first collaboration between the Upper Hand podcast, the BSSH, the Journal of Hand Surgery European, and FESSH to talk about your favorite thing.
Well, I think we're going to talk about my favorite thing, but we're not necessarily doing a partnership for our favorite thing, unless you want to. We can talk all about nerve with our European colleagues for many, many episodes if you would like.
No, thank you. Good point. I do not only want to talk about nerve, but I have humored everyone, and we're going to get through this nerve podcast.
Fantastic. Well, we already did our multi-part series on radial nerve palsy treatment, so we're dragging you back in. But this is a little bit more of a bread and butter topic, so to say. We're going to talk about carpal tunnel syndrome. Do we need to change how we do things, or should we stick with the tried and true? But why don't we first introduce our guests?
That would be great. I would love to introduce Amy Moore, who I'm sure all of our listeners have learned from previously. Amy is a long-term friend who I've known, I don't know, 15 years maybe, given her first stage in her career at Washington University in the plastic surgery division, and now is chair of plastic surgery at the Ohio State University. Amy, welcome.
Hey, thank you so much. It's great to be here and love being here with the friends. You guys are always makes me smile and laugh, so this will be fun.
Indeed, it will be fun. And our other guest is Dominic Power from the United Kingdom. So it's morning here in the US and it's afternoon in the UK. So thank you for joining us. Dom is a hand and peripheral nerve and brachial plexus surgeon in Birmingham in the UK. He is incredibly well known and funded funded for his research and well known throughout the UK and internationally. And he is on the board of directors for the Global Nerve Foundation, which I have started to work with. And I've enjoyed learning from Dom and excited to see him. I think I'll be over there in February as well. So Dom, welcome to the podcast.
Great, thanks very much. It's nice to see you all. And it's great to be talking about nerve again. It's a great thing that you're doing with this podcast, and I've watched with interest. So it's really nice to be able to take part finally.
So super excited. We picked out some articles which will be listed in the show notes from the European volume of the Journal of Hand Surgery. And the topic really centers on carpal tunnel syndrome and what we could potentially do to maybe improve our diagnostics, maybe improve our treatment and our outcomes, and then how to deal with the patient who has recurrence potentially of symptoms. So why don't we jump into the first article? The first article that I wanted to talk about really revolves around the diagnostic dilemma. You know, perhaps the patients who have electrodiagnostically negative studies but end up having a positive ultrasound. How often do you see that in your practice, Amy?
Yeah, I mean, nowadays, I'm going to just give my disclosure is that I'm seeing more revision surgery than versus primary. But I have the, more of the professionals who come, like our neurosurgery residents or, others that are younger, but have the symptoms of carpal tunnel syndrome, but they don't have electrical evidence yet. And so that is where we sit and know it's coming. So I think it's, though, a small portion of my clinical practice now. It is ones with maybe a little more high, intensity of just wanting to do the right thing. So this is really great for me. Glad to talk.
Yeah, and Dom, maybe a brief overview on your patient population that may be clinically positive and electrodiagnostically negative.
Very similar to Amy. Most of my patients tend to be the problem diagnosis or previous failed surgery. Unfortunately, they're great. They're an interesting challenge, but I don't tend to see so many of those early stage carpal tunnels. Just a word that probably we should throw out there is that negative neurophysiology with classic symptoms, there can be other diagnoses explaining what's going on. So it's always really important to do a thorough overview and look for some of those other causes before we make a diagnosis of neurophysiology negative carpal tunnel.
And maybe sorry, Chris, and maybe for our younger listeners or for people like me who don't live and breathe nerve, what are some of those other diagnoses that you immediately think of with a negative carpal tunnel nerve study?
I mean, for me, what I think about, the first thing I don't want to miss is something that is not peripheral nerve related, so a competing neurologic diagnosis that is central. But then I think about the cervical spine, I think about cubital tunnel syndrome, I think about TOS. And I think all of those things you can get a reasonable sense of based on clinical exam and history. We'll talk about this. I have found ultrasound very helpful in this kind of gray area patient, but to many of us, and we've seen clinical practice guidelines evolve this way. This is a clinical diagnosis more than anything else. And we know that the editor-in-chief of the American Journal, Brent Graham, has done a lot of work in terms of developing scoring systems like the CTS-6 that are very helpful. And in this article from Jane McEachin's group in the UK, I thought it was a little disappointing they didn't implement the CTS-6 as part of their gold standard in terms of scoring for clinically relevant carpal tunnel syndrome. But perhaps it's just not part of their practice in Edinburgh.
Yeah.
Oh, I'm sorry. Go ahead, Amy.
Yeah, my only thought also is that it's a great study because they have so many patients and they had so much follow-up. So that always is impactful, which I think is adding to it. But it also, I think if it's less than 50 and their criteria was greater than 42, so the VOSLI. So I think it was sort of their diagnostic was also including more people on their NCS than maybe I would have. So who knows what that means? And not all of them got injections with steroids, which I thought was also an interesting between the groups to know, okay, well, am I going to inject with a steroid to see if that's going to help? And I think that didn't bear out from that study.
Yeah, that's exactly my follow-up question. So maybe Dom, I'll start with you. In this patient where there's no obvious other diagnosis, you do believe the patient likely has carpal tunnel, but the nerve studies are negative. What is the role of a diagnostic corticosteroid or therapeutic corticosteroid injection for you?
Was that addressed to me?
Well, to start, thank you.
Yeah. I use carpal tunnel injections quite widely for diagnosis, see if we can alleviate symptoms. Also in this very early stage, I'll look at exacerbating factors, I'll look at wrist splintage, I'll look at, as we said already, looking at those other potential causes. And I see this group of patients as well that develop symptoms coming on during the day rather than at night, with some sort of inflammatory component and maybe some tenosynovitis, perhaps associated with tendon adhesions or tendon anomalies around the wrist, particularly patients using lots of keyboards or using lots of workstation. So yeah, steroids injections are helpful for me because if you get a good response to surgery and then a relapse, then I think they're the sorts of patient that I would then offer surgery to.
Amy, is similar approach and similar perspective?
Yeah, so I don't know what to take from the steroid injection. So I maybe that's I haven't implemented it into my practice, if I'm just going to be completely honest. Sometimes I will when I don't really know, and it's a patient that I'm, I have worked up through therapy. I honestly, a lot of patients who have muscle imbalance up near their neck, and that sort of comes down to where they're working and how they work and how they sleep. And so when they're negative on their electrodiagnostic, then is that steroid going to tell me if I think I've narrowed out everything else? So I do use it, but it's not as clear cut as it sounds like for Dom. Chris, do you use this?
I have found myself using injections less for diagnostics and more for as a temporizing treatment, and I counsel patients as such that it is likely not a cure, although I think we are biased as surgeons to think that the only cure is surgery. If they fail splinting. But instead, I think there's a lot of literature in the non-surgical journals showing that injection can be a cure. But I think the most recent article that we read, Chuck, in one of our hand service journal clubs, said that 85% of people who had a carpal tunnel injection still had surgery within a year in that study. So, and that was a European study. So for me, I use that number now. But I in the diagnostic dilemma case, I've leaned more into ultrasound, and I found it incredibly helpful, in my practice, just kind of point of care ultrasound that I do quickly just to measure the diameter of the nerve. Has Dom or Amy, do you use ultrasound? I know Chuck doesn't because he's just moving too fast, can't get access to the machine.
You guys have high volume. Dom, what do you think? Do you use it?
I haven't really started using it widely. I've got a point of care ultrasound that I use in clinic for looking at other things, tumours and lumps and so on, but I'm not the most skilled ultrasonographer. And I think the more you do, the more adept you become, and the more it becomes just part of your diagnostic tool in your clinical examination. And I think that's where I'm moving towards. Our access to formal radiology for ultrasound is so delayed and so difficult that I haven't found a need for it in my normal practice. But I was really interested in the papers showing how it's being thought of now as a really reliable tool for adding where there's uncertainty to try and help with that diagnosis, and perhaps as a screening tool in the future. So yeah, I think my practice will continue to evolve, and it'll take a more active role, but it's not universal in my practice at the moment.
Yeah, I love ultrasound. I have a great team, like our neurologist does both the NCS and then also the ultrasound. I don't personally do it, although we've just priced out to get a machine in the clinic. I'm excited to use it because now I'm having to wait so long to get my patients into the physiatrist and or the neurologist. And not that they don't want to help me, but I want to start doing more injections with it. And so I think it's going to be a higher role in my practice, but I definitely, this is the patients that I'll send for electrical diagnostic study and ultrasound. And I find it to be helpful. Ideally, I would get them out of the not doing the NCS because it hurts. Patients hate it. I'm doing this clinical trial now, trying to, prove that nerve stimulation helps in the compression, and getting them to come back, patients to come back for, diagnostics afterwards. It's hard. It's hard to convince them to just do it because we want to study it. And so I'm glad it's not our primary outcome measure.
Don't tell me that, Amy. We're about to enroll in your study. So.
Okay, well, you convinced them that you're much more charming than I am, Chris. So
I find that incredibly.
But I will tell you, that's the hardest part. But we'll get the pinch and grip because that's going to be it for us.
It's super interesting. And as Chris said, I don't personally use ultrasound, but I do have the benefit of physiatry partners who will perform our nerve studies and often get ultrasound. I do think it's helpful. And there is no doubt that the landscape is changing in front of our eyes regarding the role of ultrasound. I do want to, maybe as we pivot to a different article, this is an interesting study to me because I think it's a study that is really hard. Well, for me, at least, I could not draw my own personal conclusions as this article demonstrated. So for those who haven't read the article that are listening, this article basically demonstrated that one can improve and may be expected to improve after carpal tunnel release with negative electrodiagnostics, but to a lesser degree compared to those who were positive on the electrodiagnostics. So I haven't experienced that in my practice. Maybe you three more experienced nerve surgeons have, but it's a really interesting finding, and it does help potentially with patient counseling.
I don't know. I'm a less experienced surgeon than you, Chuck, but I have found this to be true. I think there is a sweet spot on carpal tunnel, and the patients who come in with electrodiagnostically negative but have CTS6 positive carpal tunnel syndrome, they respond. They're just not the home run when you get into that sweet spot of the patient who has early electrodiagnostic findings but no signs of denervation, no advanced clinical findings. That is a harder patient to make better. So Dom, I cut you off, but I mean, this has been my experience.
No, absolutely. I agree with everything you said. I think the sweet spot is that patients with more advanced carpal tunnel, certainly in the UK, I'm interested in Jeremy Bland's work, which is 7 grades of carpal tunnel. Those patients with 3, 4, and 5 are more likely to get a positive response on those very early stage, 0 and 1s. Now, that may be that their symptom profile is different, there's less reversible compression, but it's also creeping into that subset of the patients with negative neurophysiology that may have another diagnosis that's been missed, of course. And so this is big pool data on 7,000 or 8,000 cases. And similarly, at the other end, those patients with the most severe neurophysiology are less likely to get a favorable outcome because their nerve is shot. So I think we have to be clear about what this paper is actually saying. It's still saying you can offer carpal tunnel surgery to patients with negative diagnostic tests, and there's a reasonable chance of getting a good outcome. But I think I would go back and question the diagnosis. Always look for that other diagnosis first. And then obviously it helps with counseling the patient in terms of defining the outcome for that particular patient. It can sort of guide, really. That's my take on it.
Yeah, I totally agree. I had a really strong fellow, Jana Dengler, who wrote a paper on mimickers of carpal tunnel. All I can tell you is that there's the scary things that you don't want to miss. And it's those who come in early with the numbness and tingling. So, but for the most part, it's just that they're earlier. I think patient setting expectations is key. And I agree with you, Chuck, that this is probably what we can use to help them, that yes, you have this early, but you may not have a slam dunk. But I think patients who come in and they finally have waited a long time to get to see the surgeon, they're ready for intervention, because the most of the time they've already been splinted and or have their therapy fail. So
let's move. I mean, I love those points. And I think that leads us to our next article. So say they've come in and they've been splinted, they've failed splinting, and then they've come in and they were tortured by somebody else and got electrodiagnostics, not by Dr. Moore. But those have come back as electrophysiologically normal. What do you do at that point? Are you going to we talked about the potential role of injection. Say they don't want to be stuck with another needle. Do you talk with them about surgery at that point, or do, like the article, the next article is Rada Savuri, and the ultrasonography for the diagnosis of carpal tunnel syndrome, and this is out of Helsinki. Do you use the ultrasound at that point? Do you just say, you know what, I think you've got carpal tunnel, let's move forward with talking about surgery? Do you think the ultrasound has value at that point? So Dom, you say it's hard for you to send people because of the waiting lists. Are you going to send them for an ultrasound, or are you going to move forward with surgery, which also might have a long waiting list?
As I said before, I'd look for other diagnoses, always continue the hunt. But if I'm convinced it's carpal tunnel with positive provocation test clinically, I'd go for either a diagnostic injection if the symptom profile is mild, trial of splintage, and if there's a relapse, and as you alluded to earlier, there always is a relapse with the steroid injection, then I offer them surgery, and I just do a standard open technique.
So no sending them for ultrasound. So Amy, would you send them for an ultrasound, or when you get your fancy new machine, that's going to cost?
Yeah, I'll do it. I mean, talk over you. And sorry, of course, the fire alarm's going off. You can't make this up. I am so sorry, but I'll be quickly. Oh no. Really so sorry. You guys keep going. I'm going to be quiet, but I think I would just offer the surgery. I'm not afraid of the surgery. People do really well after carpal tunnel release. And so I think that's where I stand on it, is that I don't go and try to find yes, I'm with Dom. I will look for everything else, but in the end, I'm not afraid to operate, and I'm not afraid for our patients. I think patients do really well with this operation. I think that we have to be mindful that all surgery has risk, but for the most part, I'm not going to keep sending for more expensive diagnostic tests just to offer them surgery.
It is. I'm struggling with this currently. In the United States, we have perhaps a more challenging group of patients that is the injured worker. And I don't know, Dom, if that is a problem group for you in the UK. And in the United States, there's such a legal involvement in everything that it really is helpful to have a firm tool for diagnosis. And so the concept of taking an injured worker with electronegative testing to the operating room is still something we can do. But then if the result isn't as expected, it's a problem. More a problem in a worker than a non-worker, or someone treated under our workers' compensation system, I should say. So Dom, how do you think about that in the UK? And is that population, like I was alluding to, challenging?
Yeah, we don't have a formal workers' compensation scheme, but many patients obviously will have work issues or work concerns, or the worry that their perhaps onset of the symptoms is triggered by their work environment. I just treat the patient as is, and I make a diagnosis and then go and pursue that. Obviously, when you're unraveling something, either a failed carpal tunnel or a patient who's got a medical legal case, positive tests and negative tests are useful in terms of trying to explain and describe their condition and find causes for it. But it doesn't really taint or affect our practice anyway, or steer us either way. I think there's enough confidence that you as a clinician will make the diagnosis and pursue it. And we're not looking for a funder to necessarily agree or not agree to pay for the care based on absence of positive tests. Having said that, a few years ago, part of the squeeze in the NHS in the UK, carpal tunnel, the whole of carpal tunnel was described as a procedure of limited clinical value. And therefore there was a sort of moratorium on referring patients. We did a quick audit, and we showed that we met all the criteria on the cases we operated surgery. So, you know, they had to have had sustained symptoms for more than 3 months, neurophysiological proven tests, or with negative response to steroids. So it didn't actually change our practice, apart from the headline act that the funders weren't going to pay for it because they didn't think it was beneficial to patients. But in actual fact, if you look at the quality of life years for some cancer therapies versus carpal tunnel wins.
Yeah.
So, you know, it depends how you look at it, but it doesn't steer my practice.
I remember that sensational period of time in which the British Society was responding. It was great to see everybody mobilize so quickly and demonstrate what we do has a lot of value.
We like to go away sometimes like Brexit, but it doesn't always work. Sorry to get political.
No comment. So this article was interesting in that, you know, I think that as somebody who's learning the ropes with ultrasound myself, you know, it's interesting that they found that the best sensitivity and specificity for the diagnosis of ultrasound was using a cutoff of 11.5 millimeters squared for the cross-sectional area, because most of us will use either 10 or 11. And then they just measure it based on where it's the largest at the entry to the carpal tunnel. So there's a little bit of a fudge factor and bias in there, because you can make it look bigger based on how you tilt the probe and whether you move it proximally or distally. You know, so there's something there that I think that leads us to maybe perhaps measure, you know, leads us towards measuring a larger nerve than perhaps what really is. And then I think there's also some people are just bigger, some people are smaller, and using a number without any sort of control, I think, has its issues. But I find it to be helpful. I think it's starting to supplant the diagnostic injection for me, as we discussed before.
Yeah, I think that's fair.
So in terms of treatment, you mentioned, Amy, that you're not afraid of offering surgery, and I think that is absolutely fair. What's your current protocol in terms of how you do the surgery before we jump into maybe we should be doing this surgery differently? So are you doing you know, size of incision? Is it under what kind of anesthesia? Is it in the office? Is it in the OR? You know, what's your protocol? And then we'll ask Dom and Chuck what their protocols are.
God, I'm such an old lady in this, because I think it's rare that I have not been forced into trying to fill in many during a day. And so it's usually if I have a carpal tunnel, like I did yesterday, it was like so nice being like, oh, this is great. So most of the time I do it under MAC. I haven't gone to wide awake, because in the office for me is I just haven't figured that out. Although our hand surgeons, you know, my partners do a ton. And so I do MAC and local. And I do big incision because I've not regretted it, and I've not had to revise any of my own. And that's hundreds of not having to revise my own. And so if it's working, why change it? And so I think that's the mentality, which makes it interesting. And I don't want to be stuck in my ways, but I think I am right now. So convince me otherwise, and then I will start thinking about it. But how about you all?
Yeah, Dom?
I'm definitely stuck in my ways. So I do a traditional open carpal tunnel under local. I used to just use lignocaine or lidocaine and a longer acting local anesthetic and a forearm tourniquet. And now I'll just do a lidocaine adrenaline. Unless there's something else going on, unless there's significant tenosynovitis or something like that, or a revision case, in which case I'll do regional anesthesia to allow me to do more extensive surgery under a tourniquet. But yeah, I just stick to what I do. Now, I recognize that the majority of my patients get a great outcome. And that's not me. It's the fact that we've decompressed the nerve, and it's a successful operation for many. And I recognize that getting the hand moving and being able to get the patient confident, start using the hand early, that's key to success. But, you know, I also recognize that innovation happens, and innovation can be for the benefit of our patients, either reduced resource use, you know, office procedures, earlier return to function, and maybe, you know, I'm not looking critically enough at the outcome and time for my patients in that first few weeks after surgery. But most of my patients who are office-based, self-employed, are back at work the same day or the next day. Those that are working for another employee maybe take a few weeks. Those doing manual workers will take a bit longer. So I don't think it's my surgery. That's just my take on it. But the reason I feel so strongly about just sticking with open at the moment is I've, in my practice, seen so many complications from other interventions, and there's clearly a learning curve. You know, I've seen a patient with a minimally invasive procedure done overseas, and the incision was a transverse wrist incision longer than my standard carpal tunnel incision. The nerve was cut in two. So, you know, I've seen all of those complications. So, and it's shocking. So I just stick to what I know. But I think even with open surgery, it's important to make sure the incision's in the right place. It's not directly over the nerve. There are refinements that we have to follow and make and continue to enforce, and therefore not every carpal tunnel open is the same. And so you have to be careful what you're looking at and how you're measuring outcome. That's my little that's my summary, really.
No, I love it.
Yeah, I think that's really well said. It's funny. I think I'm similar in some ways to both of you. So I was taught how to do a carpal tunnel really by Tom Kefauver at the University of Cincinnati during my fellowship 20 years ago. And I do the technical part exactly the same, 2-centimeter incision directly over the carpal tunnel. I find visualization is excellent, and I'll make a larger incision if need be. I have evolved, if that's the right word, and I'm doing most of my carpal tunnels under local only, and have been really, really happy with that approach. I do it in the operating room, and that's a systems issue here in St. Louis. So I've been happy with that. You know, Amy, the length of the incision, honestly, I don't think it changes a thing, because if patients have pain that limits them post-operatively, it's because of the incision directly over the carpal tunnel, and extending it a little bit distally doesn't matter. So no judgment, I would hope, by anyone on that. What's interesting is I tell patients the carpal tunnel surgery is one of my favorite surgeries because the results are so reliable and so predictable and so good. But we all know there's that subset that just struggles for whatever reason. And I don't think, like you, Dom, I don't think it's technical. I think it's just the patient. There's patient factors, or there's work factors, or there's life factors. But what a great surgery. And there's a lot of ways to get it done. Chris?
Well, I mean, just for context, I am also, like you, do similar surgery. My incision is probably 2.5 centimeters if we're measuring. I know, it's crazy. Wallant style. Yeah, exactly. In the not in the office, and like you said, systems issue, but no tourniquet. And the vast, that's pretty much my standard unless the patient asks for something else. So I think it's interesting that, I just see a number of patients that have a painful scar and or this vague concept that we call pillar pain. And I see enough of them where it's a little frustrating, which is why I'm interested in maybe there's a different way to do this. And the next paper that we want to talk about is from our friends at the Mayo Clinic, talking about doing an ultrasound guided thread carpal tunnel release, which when I first heard about this, I thought was absolutely nuts. But during my travels for the American Society's Gelberman Fellowship, I went and was visiting the Plexus team at Mayo, and I saw Alex Shin, an incredibly talented surgeon, do 13 of these in an afternoon with Jeff Bro, the physiatrist, which anybody who knows Alex, and I say this in a very loving way, it's pretty classic of Alex to go really hard on something. So he did 13 of these in an afternoon. That's a pretty standard thing for him, apparently. And the procedure, he's very skilled at it. Jeff and Alex have a great system of doing it. And it got me thinking, is this something that, is there something to doing this surgery in a different way that will get people back faster? Amy or Dom or Chuck, have you considered doing anything either in the endoscopic realm or ultrasound guided to perhaps get to a subset of patients that might benefit? Maybe start with Amy and then go to Dom.
Yeah, I trained with Alex and that team, and I actually saw them do a case, and I'm not sure if it was when I was visiting or what having, and it's very, I think probably has a pretty high learning rate for it, curve. And seeing somebody who's very thoughtful like Alex about nerve and nerve surgery, his adoption, I think, is helps me think like, oh, maybe this could consider it. I think I just have to rely on my bias, and my bias is I see people's complications. Have not seen any complications from threaded, but I don't think it is done as much as endoscopic. And so I think it's rare that I'll see a complication from open surgeries. I see them from the endoscopic. Again, bias. And I think I always say, if anyone asks me on stage, I'm always like, you do what you know how to do. And like, you stick with what you know how to do and make sure you do do it well. And so I think it's a cop out. Sorry, Chris, it's a cop out. I think, yes, you do what you do. And I'm going to stick to my open and probably be less into the threaded, because it's just intimidating to me not to be able to see as well. And I don't have the ultrasonographer right there beside me making it happen.
Dom, do you feel the same way?
Yeah, as I said before, you've got to see the need to change. Clearly, we need innovators, and the problem is that those experts and early adopters doesn't necessarily translate to the rest of the population. You know, we're not all good at reading ultrasound. We're not as good at looking in a 2D and trying to assume what a 3D structure looks like. That's the challenge. Anything that improves your visualization to allow you to do smaller incisions is something elsewhere in the body that has been accelerating in the last 30 years, hasn't it? Laparoscopic, endoscopic procedures, short stay in hospital, reduced recovery times. For us, when it's already a simple day case procedure, those gains may be more marginal, but they may be there. We just need to look for things like pillar pain. It might be we need to treat huge numbers to make a significant impact on our population, and then at what cost? You know, if the iatrogenic injury rate goes up from 0.25% to 5%, that to me is an unacceptable cost. I think ultrasound guided minimally invasive procedures is an exciting way to go. Seeing the nerve, seeing where it is, and making sure it's protected all the way through, yes. In my hands at the moment, no. I just don't have the skills or the time to invest, to develop, to become comfortable. But I watch this space with great interest. I think it's a really interesting concept, but like Amy, endoscopic for me is not sufficiently robust in terms of visualizing the nerve and knowing that the nerve is absolutely safe throughout. And because of the complications, I wouldn't do that in my own practice. So
Chuck, not so old dog with the new trick, maybe?
Yeah. So Chris will like this. I have two comments here. I always have two comments. My first is that I have gone the route of endoscopic previously, and I liked it. But Richard Gelman said something that has stuck with me to this day, which is basically a question that when you finish an endoscopic carpal tunnel, have you really added stress to your day, a little uncertainty about being 100% positive that you completely released the carpal tunnel, and positive that you did everything in your power to help that patient? And he was right, because when others who are more experienced perhaps with endoscopic may see it differently, but it wasn't satisfying for me in the same way that an open carpal tunnel is satisfying. So I stopped. There's another system I'm evaluating currently, but I'm really happy, as both Dom and Amy said, with what they do now. And the results are predictable, reliable, and I like to provide that surgery for my patients. The second thing I'll say is that I also agree, while I may not be a regional or national referral center like Dom and Amy and Chris, I see my fair share of either patients in the clinic or legal issues regarding nerve injuries. And while the literature would tell us that open and endoscopic have similar complications, I don't buy that a bit, because I just don't think I think it's I'm not questioning the authors, but I don't think there is accurate reporting of the rate of injury with endoscopic. And what probably is necessary is a group like you guys all putting together your revisions or nerve repairs, and then looking back and seeing which of those were endoscopic and open. So I think it's a fascinating topic, but I don't buy the literature that says there's an equal rate of risk with open and endoscopic.
Yeah, I totally agree with that. I mean, you talk to a couple of the surgeons who have one injury, and it's just devastating, right? And so I think the reality is probably underreported. But again, that's my bias, so I'll be quiet. I've disclosed it.
Don't be quiet. I think that's reality. We all have bias in our practices. I mean, I think that, and then also you have complications with open surgery too, that are underreported. So I think that the iatrogenic complication rate is higher than what is in the literature. And, but I don't think that bias is going to change. One question I wanted to ask the group to pull us back towards the article. I think that the way that this group defined return to work, although they tried very hard to make it objective by keeping everybody through occupational health and in the same health system, I think return to work is just such a hard outcome because it's so individual, both at a patient level and a job level. So I don't know if and there's bias, I think, in how like we discuss return to work. If you're going to discuss a less invasive technique, you're probably going to put it in the context of an earlier recovery, whether that's work or recreational sport activities. So I think that's a little bit of a limitation here. Dom, you mentioned with your patients, some people will go back to work on the same day. I think Americans are not that tough. So they want more time off of work. What do you say your average return to works are just for people who work at a desk, people who have some elements of heavier labor, and then a true manual laborer? And then I'll ask the same question of Amy afterwards.
Yeah, it's again, as I said, it depends on someone's root motivations. Generally, if they're doing office-based work, I would be encouraging them to stay away for somewhere between 2 and 4 weeks, knowing that keyboard use and prolonged keyboard use can be uncomfortable. Light manual 4 to 6 weeks, and heavy manual, we can't kid ourselves, sometimes takes a little bit longer, but 6 weeks is a sort of, I would be very disappointed if everybody that I've operated on isn't back and almost forgotten about their surgery by 6 weeks. That's the problem, that, those that have got pillar pain or persistent scar tenderness, yes, there's always a few, and that's the group that we should try and improve. They'll take a little bit longer sometimes.
Yeah. Amy, same question to you.
Yeah, I think, for sure within 2 weeks, I think 5 days, so I operate on Tuesdays, sometimes Fridays, but Tuesdays, and they're back to work by Monday. And I haven't felt that that's been not appropriate. I don't let people, I always say, when you make a fist, all of your tendons pop to the front, right? And if the nerve is sitting at the top of that and you're gripping hard, I think I just want to avoid that. I want to keep all of your nerve gliding and trying to minimize the scar tissue that's being stuck around. And so I will say, I don't want them lifting more than a half a gallon of milk for the first 2 to 4 weeks, and then a gallon of milk from 4 to 6. And then after 6 weeks, you can lift whatever you want. And so my manual laborers, I put them on restrictions for weight, until 6 weeks. And I haven't had any pushback. And yes, there's definitely those who have the hypersensitivity or, the pillar pain. And we should talk about pillar pain maybe, because I don't know what it is really, right? I think it's that we've cut between the two muscle groups and now they're flying loose and they're just having to resettle. But I think massage is going to be the best thing for it. But by 6 weeks, they're back at work. And I think, 5 days back is fine. And I want them typing and eating with their hand on the same day. But the return to work, I completely agree. I think return to work is such a nebulous concept and such a personal one that I would hate to say that, because this paper said it, all my patients have to be back to work within 12 days, right? That's not an expectation I want, the insurance companies getting or, other occupational health getting, because I think when someone chooses to undergo surgery, it shouldn't be seen as, getting your eyebrows waxed, right? It just shouldn't, right? I just don't think it's as simple. And so, I don't know.
If someone waxed my eyebrows, I think I'd be off for at least 2 weeks. Probably wearing a paper bag.
Again, I probably shouldn't have used that analogy, but I think it's something going in and getting whatever. It is surgical. It's not to be minimized. It's, that's the #1 litigation under nerve surgery in the US is for carpal tunnel syndrome and releases that have gone bad. So I think we have to just sort of use that as the sacred space. And so telling somebody that you're going to absolutely feel good by 12 days is, I think, unfair.
I learned a lot from Chuck, and Chuck takes care of a lot of injured workers. And, Chuck, maybe you could say, I remember you saying that pretty much everybody gets back to full activities by a month. And I think that's the baseline you said, but I think people's trajectories are different.
Yeah, I like the 5 day. Essentially, all my patients go back to work at 5 days, but they might be light duty. And then I shoot for a month. Now, there's some workers that require a little longer, but a month, 6 weeks, I think I agree is probably max. I'll be disappointed if it's not 6 weeks. So I like those timeframes, and I like the graduated lifting that Amy described as well. So clearly an imperfect science, clearly.
Do any of you place any restrictions on your patients after surgery, aside from, Amy, you mentioned the lifting, the amount of lifting, but, I guarantee you, if any of the four of us had this surgery, we probably would be doing much more than what we tell our patients to do.
That's right.
Oh, I've taken care of enough surgeons who go back to work really quickly and then they ache for longer.
Right.
And so I mean, that's the truth. And so I was like, I know you're gonna go back to work, but I'm telling you, if you could take the time because you're gonna hurt longer. I don't know, Dom, what do you think?
Yeah, I encourage functional use of the hand because I think wrist extension with finger flexion is a way of getting glide and keeping the nerve away from prolapsing into the scar. So I think it's important to functionally use the hand. It is so subjective, isn't it? What someone does and their perception of what they can do. And I think particularly with the response to overprescribing of opioids, what we probably need to do is have much more stewardship about what's expected and how analgesic is used in this population. And I think this is part of the pre-education. If you explain to patients that what's expected and you talk to them realistically about the journey and that they will have some discomfort, then their whole post-operative period is much more torrid. If they expect it to be pain-free surgery because you say, oh, it's only a tiny operation, and they'll be disappointed. So I think we have to do a lot better as well in our run up to surgery for patients and bring them on the journey with us. And I think that earlier investment of time speeds up their recovery.
Could not agree more. I guess as we bring this to a close, it's been a fun journal club discussion. The last article is out of I think it's out of Verona, and the first author is Carita, looking at if patients have a failed carpal tunnel decompression, either recurrent or persistent symptoms, and the use of ultrasound. Now, just quickly to hit this. So, Amy, do you use ultrasound in the evaluation of the patient with potential persistent or recurrent symptoms? And either way, whether you use ultrasound or not, what do you find in surgery typically in terms of, is there residual point of compression, incomplete release, reformation of whatever you would call the transverse carpal ligament at that point? And then same question to Dom and Chuck.
Yeah. And I've learned from you when we talk about this, but as we also refer to it, like you have to understand, is it new, is it recurrent, or is it persistent? And so that's beyond today's talk. But I think every time I see a patient who has not had the expectation of recovery that we would from an open release or an endoscopic release, or just primary release, let's refine it that way. Then I'm searching, and I love ultrasound for that reason, because then you can see changes in the nerve, and it helps in myself, framing, okay, well, if I'm going to find it, am I going to need to graft? Any revision surgery just takes longer no matter what. Intraoperatively, I've found distal failure to release. And it's also where I found the most injuries, is at that third web space, unless it's just catastrophically proximally cut. So I guess I've seen both. And I think ultrasound is very helpful for me. It doesn't determine if I'm going to go to the operating room or not. And I think that's the part where I've been much more, because it's so hard to get people in. I probably steered away from it, because until I get it in my own hands, I think it's just, okay, well, let's go back and explore, because this can't be what you have the rest of your life.
Got it. Dom, similar findings and thought process?
Doubt the diagnosis, doubt the quality of the surgery, and doubt the condition of the nerve. So I always do neurophysiology again. I always try and get hold of the original operation note and see who did the surgery, what the grade of condition was prior to surgery, whether there was a spontaneous recovery and then it relapsed, or whether it never got better, whether symptoms changed. But I tend to always make sure I've got neurophysiological studies and try and compare them to pre-op if they've been done. I have to say I rarely would do ultrasound routinely, because I think we know the nerve's not going to glide very well. We know it's going to look swollen proximally. I'm not completely convinced that when ultrasound is done, someone can say that's the original flexion at acting that hasn't been released. I need to visualize it. So they normally end up with surgery and regional block, extensive surgery, and a further look at it. So not a huge part in my practice, unless there's something else odd, a swelling, you're suspicious of some other pathology in the carpal tunnel, then an MRI or ultrasound. But it's not a big part of my practice at the moment. But again, I think it comes back, like you, Amy, to having delays to getting that sort of imaging available to you. And once it's at the bedside or in the office, and we're comfortable with it, we'll be using it as part of our clinical examination on many patients. So it doesn't cost anything. It's not painful.
Yeah. Chris, what about you? Can I ask you and Chuck?
So Chuck, why don't you go first, and then I can give my thoughts at the end.
Yeah, I think Amy and Dom said it beautifully. And I would just say that for me, I will occasionally use ultrasound as a surgical planning tool, not to help me determine whether or not to go to the operating room, but it can be helpful. And, you know, is this a 30-minute revision carpal tunnel? Is it a longer? Is it a more of just another carpal tunnel? So that's how it helps me. But Chris, you may have different thoughts.
I agree, surgical planning tool. Also, it is helpful for me in terms of evaluating completeness of release. I do not trust prior operative notes. I doubt the prior procedure. I doubt the prior nerve studies. I doubt everything, like Dom said.
Awesome.
What's interesting is that, you know, the only point I'll make is I think that in my experience with revising carpal tunnels, it's not necessarily the distal point for me, which I know is different than what Amy said, different than what's in this paper, and different than what's in the larger series from Stutz many years ago. To me, what I usually see is an incomplete release proximally, or a nerve injury proximally, but always looking for, you know, that distal third web injury or the incomplete release by the arch. But for me, it's been at the risk crease from when I've had to revise you know, the surgery of others who have come in. So, you know, I think that there's a lot to learn from this. I encourage our listeners to review these great articles from the European volume. We'll have them in our show notes. This has been a really fun collaborative, and really I wanted to shout out the people at the BSSH, obviously Dr. Wee Lam, who's been incredibly helpful in facilitating all of this, and Emily Lakin at the home office for the BSSH, Dr. Jebba Batten, who's going to be working on the social media front for this. So thank you to the BSSH, JHS Europe, and FESSH teams for that. Dom and Amy, thank you for joining us. It's been a lot of fun catching up with you guys. You're always fantastic guests, and I've learned a lot from both of you. Thank you.
Thank you.
Thank you. It's great to be here.
Yeah, thank you so much. Who would have thunk that I would enjoy talking about nerves, even with you guys?
We're going to continue to convert you. We're going to continue to convert you, Chuck. It's
closeted nerve nerd over there, Chuck Goldfarb. But have a wonderful day and afternoon, everybody, and we'll talk to you next time.
Cheers.
Bye-bye. Thanks for this.
And he's
I'm trying to